Thanks, Bob. What Bob hasn't mentioned is that actually what the four presenters are going to talk about today is going to form the basis of a series of consensus statements that ACP-GBI are going to put out later on this year, which will hopefully be published in Colorectal Disease. However, what I'm going to talk about is to review the evidence for the management of complicated and uncomplicated diverticulitis. However, this is what I'm going to talk about. At the end of the next 15 or so minutes, these are the trials that I'm going to want you to know about. I'm going to talk about ladies, both arms, Lola and Diva. I'm going to talk about Lapland, which is currently ongoing. I'm going to talk about Scandiv, Dilala, Avod, Diabolo. Because one of the great things about diverticulitis is there's a lot of trials about at the moment trying to answer the question, what should we be surgically doing about this condition? The reality is there's a lot of it about. Everybody I seem to scope over the age of about 50 seems to have some diverticular, but actually the reality is that 80% of the over 80s will have extensive diverticular disease. It's pouching of the actual outlining of the mucosa through the wall of the bowel at the site of the entry of the colonic arteries. It accounts for a significant amount of our colorectal workload, approximately 209 admissions per 100,000 population per year, and it's supposedly associated with this presence of a fecal issue within the actual diverticulum. Up to 35% of cases will be complicated acute diverticulitis. As you all know, it presents with left iliac fossa pain, generally a fairly short history associated with fever, rigors, raised CRP, raised white cell count, they'll be tender, they may have a mass, and so forth. And the differential diagnosis is various gynae conditions, reproductive, other conditions within the GI tract, which you all know. Hinchey is to diverticulitis what Duke's was to colorectal cancer staging. The advantage of Hinchey is it's provided us with four essentially different ways of classifying it, and as you'll see, this has been very helpful in terms of stratification of patients into the various trials that I'm going to talk about. So Hinchey 1, for example, mesocolic inflammation, all the way down to Hinchey 4, perforation, fecal peritonitis. So Hinchey, described in 72, still useful today in terms of our trial stratification. The first recommendation we've got in the consensus statement that we've written is that all patients should have a CT scan within 24 hours of admission. You could say that's controversial or not, but that's going to be our guideline. Reason being that CT has a very high sensitivity and specificity for the diagnosis of diverticulitis, and also allows you to stratify it into both uncomplicated and complicated forms. For me, ultrasound scan is simply too low in terms of its sensitivity and should simply be reserved for hepatobiliary doctors diagnosing gallstones and entertaining ladies with right iliac fossa pain. I don't think there's any role for ultrasound scan in the management of diverticulitis. There is an Ambrosetti modification of the Hinchey classification which actually takes account of CT findings, and what you see is that CT is actually going to show you these kind of abscesses which helps you with how you define your Hinchey classification. So Bob's already alluded to back in the day, early 90s, I was Bob's SHO in Nottingham, and this was the conventional treatment. Everybody with diverticulitis in you came, you got some intravenous Kef and Met, nobody ever did a CT scan, and basically you either got better or we did a Hartmann's procedure on you. That was pretty much it. I don't recall ever doing the CT, percutaneous drainage, while we were lucky to find any radiologist at all. That was back in the day. These are two trials that I need you to know about, the Avod trial and the Diabolo trial. And what these two have done is they've looked at CT stratified uncomplicated diverticulitis, and they essentially, as I'm going to show you, will show that you do not need to give these patients intravenous antibiotics. So what about the two trials? They were similar but slightly different. Avod and Diabolo, both multi-center trials. Avod 11 centers, Diabolo I think was 22 centers. Population slightly different. Diabolo just looked at primary diverticulitis. Avod, actually 40% of the patients recruited had recurrent diverticulitis. All patients had a CT scan. All patients had uncomplicated diverticulitis. All patients were therefore Hinchey 1 in terms of their stratification. Slightly unhelpfully, the actual treatment regimes were slightly different. In Avod, all patients got 7 days of antibiotics, or at least the intervention group got 7 days of antibiotics. But there were various antibiotic regimes that they got. In Diabolo, all patients got Augmentin. They got it intravenously for 48 hours, and then they went on and had a further 8 days of oral antibiotics. The control groups were no antibiotics. Patients were simply admitted, though in 16% of cases in Diabolo they weren't even admitted, and they compared their primary endpoints and secondary endpoints. And the primary endpoint in Diabolo was time to full recovery. And full recovery basically means no surgery, no medication, completely recovered. So Diabolo looked at 6 months, AVOD looked at 12 months. And what they showed was there was no statistically significant difference in primary endpoint between those patients receiving antibiotics and those patients who did not receive antibiotics. The secondary outcomes from Diabolo, resection rate, recurrent admissions with diverticulitis, once again, no difference in secondary outputs or secondary endpoints. So this was a study from Norway which essentially took that premise. Can we admit patients with uncomplicated diverticulitis on a CT scan and simply not give them antibiotics? What's going to happen to this group of patients? So in January 2013, this group in Norway simply changed their strategy for how they're going to manage these patients. So they admitted 177 patients over this time course, and what they found was essentially that you can get away with this. There were 1 or 2 treatment failures as patients deteriorated, 5 required antibiotics, 2 were readmitted, 8 patients had recurrent disease. But then within the scheme of 177 patients, this was similar to what was found in Diabolo, where literally 90% of patients just simply get better without any antibiotics at all. So the reality is it can be done in an individual centre. I'm going to move on to complicated diverticular disease. So now we're talking Hinchey 3, Hinchey 4. And these are all the manifestations of complicated diverticular disease. Perforation, fecal, purulent, peritonitis, abscess formation, fistula, bleeding, and stricture formation. So originally, this was the treatment of choice described by Henri Hartmann, exterioration of the proximal colon, stapling of the rectal stump, depending on the comorbidity of the patient, a morbidity of anything up to about 35%. The problem, as we all know, with the Hartmann's procedure is that half of all patients simply don't get a reversal of their colostomy. The other problem group are the 50% who do, and anybody who actually does a lot of reversal of Hartmann's will tell you it's not a great day at the office. These are technically demanding operations to do, whether you do them laparoscopically or open, and the actual leak rate from a reversal of Hartmann's has been reported to be as high as 10%. In our own series of laparoscopic reversal of Hartmann's, this group had the highest conversion rate of all the patients that we did laparoscopically. So there have been a number of proposals for things you can do for complicated diverticulitis that aren't a Hartmann's procedure. So, okay, we resect the diverticular segment, well, we'll put it all back together. So we put it all back together. We might want to give the patient a loop ileostomy to try and protect our joint line. Well, if we're going to do that, we might need to mobilize the splenic flexure, mobilize the hepatic flexure, do an on-table colonic lavage. Not terribly popular in theatre, in my experience. But these are all things you can do to avoid doing that Hartmann's procedure. Laparoscopic lavage, quick, simple, could be done by the majority of GI surgeons. That was the new kid on the block described in 1996. Other options out there, simply close the hole, pull up a stoma proximally, plus or minus a drain, maybe resect the diverticular segment afterwards. These are all options that have actually been considered for the treatment of complicated diverticulitis. And there were quite a lot of trials that I'm briefly going to mention that came out in the early part of this millennium that actually attempted to differentiate between which of those options was actually any good for the patient. So this trial, actually, small study, 60 patients, and they simply looked at doing Hartmann's versus doing a primary anastomosis. And what they found was the primary anastomosis group had 3 leaks out of their 30 or so patients. But what they also found was when they reversed the Hartmann's, they also had 3 leaks. So essentially, you might not have leaked first time round, but you did when they closed the stoma. So they concluded that actually doing a primary anastomosis in this group is not an unreasonable thing to do. This study, pretty much exactly the same, roughly around the same time period, 70 or so patients. The issue they found was that there was actually slightly more complications in the Hartmann's group than there were in the primary anastomosis group. Another trial, similar sort of period of time. As I say, these were all at the turn of the millennium, slightly bigger, 105 patients. They looked at primary resection, either with or without an anastomosis, with or without a defunctioning stoma, and they compared it with simply closing the perforation, pulling up a defunctioning stoma, and then doing a resection at a later date. And they found there was no statistically significant difference in terms of mortality, but there were a lot of post-operative problems in the simply closing a hole, pulling up a defunctioning stoma. So it seemed to be that this option was not going to be a long-term one. A similar study from Professor Kronberg's group, slightly smaller numbers, and in this case they actually resected the sigmoid colon, the diverticular segment, and compared that with a transverse colostomy, suturing and mental covering, and they found no significant difference at all. In truth, the only time I've ever employed this sort of strategy in management of complex diverticular disease is when the patient is so unwell, they simply have to have something very, very quick and get off to ITU. I think it's generally discredited, though there was evidence early on to see whether it was a benefit. As I've alluded to, the new kid on the block was laparoscopic lavage. The Cochrane review from 2010 looked at about 231 patients. There were no randomized controlled trials. They found that results were promising. Mortality was low. Obviously, you didn't get a stoma. Morbidity was also low. And really, from that came this study that I want to talk about, which is the Ladies Trial. And Ladies Trial, big study, multi-center, lots of teaching hospitals involved. And essentially, there were the two arms of the Ladies Trial. Lola, laparoscopic lavage versus Hartmann's. That's Hinchy 3, purulent peritonitis with a perforation. And DIVA, the other group, which is ongoing. Lola has reported, DIVA hasn't. But DIVA essentially is a Hartmann's procedure versus resection with or without a primary anastomosis in patients also with feculent peritonitis, as distinct from Lola. So who actually went into this Ladies Trial? Well, patients with generalized peritonitis, they didn't necessarily actually have to have a CT scan. They could have evidence of free air on an erect chest X-ray. And the reason for this is that what they ended in this group was go on and laparoscope them. And once they'd laparoscoped them, they then randomized them to actually whether they should go into DIVA or into Lola. So it's Hinchy 3 in both groups, Hinchy 4 in the DIVA group only. They excluded the standard exclusion patients who couldn't give consent if they'd had a previous resection, obviously, steroids, pelvic irradiation. Now, Lola has been reported. It was reported by Sandra Venix in an edition of The Lancet in September last year. This trial has stopped early. And the reason it stopped early is because there's an increase in problems in the laparoscopy group as compared to the Hartmann's group. To my mind, it didn't look like there was such a big difference, but actually the trial has ended, and the conclusions is that even though there's no difference in mortality, laparoscopic lavage cannot be continued. Different trial, similar question they were answered was the Skanda Trial, another European trial, big centres, big numbers of centres involved, 21. It's been running for a little while now. Once again, patients with perforated diverticulitis. These patients also had a CT. The issue with these trials is you can screen a lot of patients and actually only end up with a reasonably small number actually in the trial. But ultimately, Scandiv had a laparoscopic group of 101 patients and 98 patients in the Hartmann's group. Anybody with Hinchy 4 fecal peritonitis simply got a Hartmann's procedure. And anybody who had any other pathology simply got a Hartmann's procedure. But what did Scandiv find? Scandiv found that there was no difference in the mortality. With the laparoscopic group, the operating time, as you'd expect, was somewhat shorter. If you don't resect the affected bit of colon, there is always a danger of missing a sigmoid cancer. But what they did find was that those patients who had the laparoscopic washout, as compared to the Hartmann's, tended to have more problems in terms of requiring reoperations and morbidity. And their conclusion was that you cannot support the use of laparoscopic lavage for the treatment of complicated diverticulitis. One of the other trials to talk about, Delala. This was also in Hinchy 3, laparoscopy followed by randomization to either laparoscopic lavage or a Hartmann's. Their results reported very early, smaller numbers than in the previously mentioned trials. They found that there was no difference in mortality and morbidity. So their conclusion was that actually laparoscopy does have a place in the management of purulent perforated diverticulitis. I'd interpret these with caution. The numbers are very small in the Delala trial. A trial that's currently ongoing, this is from Des Winter's group in Dublin, slightly different from the other trials going on. This one compares laparoscopic lavage versus a Hartmann's procedure or a primary anastomosis. It is ongoing. They're aiming for big numbers. It's going to hopefully rival some of the European trials. Inclusion and exclusion criteria are very similar to the other studies that have been reported. Briefly, other manifestations of complicated diverticular disease, colevozycal fistulae, evidence of contrast within the the actual bladder. To my mind, these patients will require surgery, though I have got two who managed to get away with conservative management and it just healed up. Colovaginal fistula, they get so sore from passing feces through the vagina that you end up doing something to treat these patients. Diverticular strictures such as this one, following a bout of acute diverticulitis, needs resecting. And when you do, this is what you get, thickening of the actual lumen of the bowel. So in summary, what I've hoped to do is present you some of the trials that are out there. Some have been published, some are ongoing. But I throw it out there for discussion. Acute uncomplicated diverticulitis, as defined on a CT scan, could be managed without necessarily giving the patient antibiotics. It could be managed in the outpatient setting. Laparoscopic lavage, been a lot of talk on it, a lot of trials on it. It's not entirely clear to my mind who's going to benefit from this approach. I think we have to be very cautious with that. I'd like to acknowledge the contribution of my colleague, Dave Humes. Thank you very much.
Thanks very much, and it's my pleasure to be with you today and share this development of the consensus on this very, very interesting topic. Why abdominal perineal excision and why this topic? There has been recently some development, and over the last 10 years, there has been more of an issue of this subject than ever before. That is because of clinical outcomes, especially with oncological outcomes, as you have noticed in this slide. There is a significant difference between oncological outcomes of abdominal perineal excision compared to anterior resection. A very remarkable difference, to the extent that it's about 2 or 3 times CRM involvement. And that is actually came to attention to a lot of people, including in this country, as I will allude to in a minute. So there are some series reporting about an advert bowel perforation in addition to CRM, a lot higher with abdominal perineal excision compared to anterior resection, even more than double or 4 or 5 times. And the question is asked why, if you offer the patient anterior resection, they have better oncological and better outcome. And these have been challenged with a different approach, saying maybe perhaps we're doing the wrong operation when you're doing abdominal perineal excision. And this has been challenged by 3 earlier studies. The first one, as you will know, from Stockholm, from Holland. And they actually extended the operation into an extra elevator. And that's been published, all of these, at the turn of this century. And they have reported more or less similar outcomes to an anterior resection operation using the abdominal perineal approach. That has been also been reported in Poland as well as in France. And what is the idea behind abdominal perineal excision? What we used to believe to be what is done is you come from the top, you narrow it down, and you stop. And then you come from below, and you will end with this constriction. And that's where most of the trouble, basically, you'll end with a specimen, and you may have seen this slide several times with this. And that is the area of trouble. And actually, basically, the recommendation say, don't do that. Don't narrow the specimen from above and having this almost bare bowel at this area where is most likely you'll have CRM positive. And that's been replaced by the novel technique. I'm not talking about novel like immediately. That has been going on for a number of years now. And so you come from above and you stop very high. I'll stop again. You come from above and you stop really there. And you come from lower down, extra elevator, and finish off instead of narrowing it here, and that is the critical zone. You basically follow the extra elevator plane, so you will end with a cylindrical approach. And this approach gained popularity, and been adopted in this country. And you may have heard, I hope you have, about the LORIC National Initiative, which was led by Brendan Moran, and to basically support adoption of this operation. Let me clarify things. I'm not here to try to defend one technique or the other. I'm just giving you the history of development of low rectal cancer surgery. And the outcome of this program in terms of perineal closure after it is still to be published. So that is the background why I'm interested in this, because the bigger you do in terms of surgery, the bigger the hole you leave behind. And that is one of the reasons why I'm here standing to you to address this subject. So we have become more radical, we excise more, we leave a bigger hole. And the debate is what to do with this hole. How can you close this? So that is after abdominoperineal, after extra levator, and basically leaving the patient with significant quality of life problems. We may have sorted out oncological outcomes, but this is resulting in significant comorbidity for patients. Now, there are various number of options to how to address this. We all have done in the past bringing a piece of momentum, try to do a primary closure. Now, there is growing interest from industry to develop various numbers of biologic mesh to replace or cover it, and of course, the plastic reconstruction is always an option. In 2012, we put together a systematic review at that stage, and that is during or just immediately after the LORIC National Initiatives. And we looked at this systematic review, basically, what shall we do with closing the abdominal perineal resection, the extra levator perineum? We looked at the literature, and to cut the story short, there were only 11 publications met the criteria at that stage. Myocutaneous flap, number of study, what I would like to bring to your attention is the number of patients. So after hearing Charles talk about all of these number of trials and the coming trials, I have not got you a single randomized controlled trial to report here. They're all case series. There are trials that are coming, but there is nothing being published there. So they're all case series with a modest number of various types of myocutaneous flaps, of various types of patients. Of some of them, they've had radiotherapy and some of them didn't have radiotherapy. So they're quite a heterogeneous group of patients. And that is the biologic mesh, again, that's even a smaller group of patients. And what we came, I'll just skip through that quickly, is radiotherapy at that stage was quite an important, significant determinant of the outcome of perineal closure. Quality of life, again, there are very little studies, very small number, hasn't been really evaluated in a proper larger study. So our conclusion that there's very little data, and there really need to put together a large randomized controlled trial. We tried to put that, it didn't go forward, and 2 years later on, there is another systematic review to step back a little bit and look after the whole entire topic of abdominoperineal excision. What is the outcome in terms of perineal wound healing following various methods of APE? So it's not just LAPE. So this one, you have APE conventional, APE extra levator, and then you have the various methods of closure. And the main finding of this systematic review is, again, the radiotherapy. Radiotherapy doubles the incidence of perineal wound complications. So it doesn't matter if you do a direct primary closure or you do a flap. It doesn't matter if it's extra levator or conventional. If the patients had radiotherapy, they will have double the rate of perineal wound complication and slower healing. And roughly in this systematic review, we are talking about 14 to 15% problems with perineal wound without radiotherapy, and if you double it, around 30-odd%, that was the rate with radiotherapy. And that's their conclusion, that there is a problem there, is a radiotherapy. If you give the patient radiotherapy, it basically, the wound, it doesn't heal perfectly. The only randomized controlled trial is just happening now. It's still recruiting, and we're waiting really to see it. Will this answer all the questions? I don't think so, because it is again comparing primary closure against biologic mesh. So the plastic surgeons in the audience here will think, well, that's not all the practice. A lot of centers, they do plastic reconstructions here. There are sometimes we can't do primary wound closure, especially for that picture with the big hole. If you remove the whole levator plates, what are you going to stitch exactly? I don't understand. When people talking about primary closure for a lab, I genuinely don't know what they close or what they mean. Is that skin and subcutaneous tissue? Well, in fact, that is a definition of a hernia straight away. So for the consensus statement, we need to update the two systematic reviews and taking into account all the other points I've just mentioned. We've put the team together, and I'm hoping really to complete it by the end of this year. What we'll be doing, well, we'll put all the search terms will be not just ELAPE, will be APE, will be all the methods of perineal closure, and of course, including all the modalities of therapy, including radiotherapy and no radiotherapy. We'll be looking at short-term outcomes, of course, and quality of life, and we'll be using the grades to score the evidence. There are 8 questions we'll be trying to address, and that is our initial plan. We might change it a little bit, but that's our initial thoughts at the moment. First one, about ELAPE or conventional. We're not arguing which one to support oncologically. We're arguing what is the impact on the perineum. Let me go through them one by one. What is the impact of perineal wound healing with using different approach? So if you're using perineal, is it different from AP or ELAPE? And is the complications different? Well, we have already some findings to say that there are some differences. Radiotherapy, I'm looking forward to seeing what we can come out of this one. We saw from the systematic review, the Dutch systematic review, that the radiotherapy actually impacts significantly on the wound healing. My question is, what should we do? We haven't got the answer yet. What shall we do? You have to give the patient radiotherapy because that is improved survival. We all know that. If there is a compromised CRM on MRI, you have to give radiotherapy. But you're left with a situation, you don't know what to do with the quality of life because this patient is likely to have perineal wound problems. So, what is the third question? Minimal access surgery, that hasn't been taken in the discussion really. I mean, APE now is almost done exclusively in centers using minimal access surgery. There are centers that are talking about robotic surgery. Where that impacts on how are you going to deal with the perineum? Now, traditionally, when we used to do it openly, we all probably used to bring a piece of omentum. Do we still do that laparoscopically? I don't personally. I don't know why. I don't know why when we change the technique of surgery, we don't do the same practice. Did that make an impact? We don't know. So we need to see what is the impact of modality of surgery on the perineal wound closure as well as outcome. What about when you try to do a traditional EPE? Has a traditional EPE its place? Probably it has, because when we went to extreme that we thought every patient needs extra levator, I think people are coming back and saying actually not necessarily, maybe a small little cancer there that might not need really to go as radical and leave significant impact on quality of life. And you will end with a traditional or conventional EPE. What would you do after that? Does primary closure have a place? Maybe. And then for ELAPE, what would you do? And with the ELAPE, you've got basically the whole basket there. I don't think primary closure personally has got any place, but it's quite interesting to see what will come with. Then there will be the debate of flaps and what types of flaps. There are various types of flaps. And if there is a mesh, what type of mesh? But we're pretty much quite clear on that one. A lot of people using biologic mesh. Perineal hernia, it hasn't been really served right. It hasn't been reported well. We don't know exactly what to do. If you give the patient a laparoscopic operation and left with a hernia, what is the definition of a hernia? Do you need to scan them to look for it, or do you need to close your eyes? What would happen if the patient develops a hernia? how would you repair it? What is the best approach to do with that? And that's hopefully what we'll be using in order to score and give them level of evidence in terms of grades scoring. And that will be based on a strength of recommendation and the quality of evidence. Thank you very much.
Thanks, Bob, and good morning, everybody. Perianal Crohn's disease has been identified as a major area of interest, particularly with respect to research, by two major Delphi exercises, one through the James Lint Alliance and one through our own ACPGBI Delphi process. And it's because of that that we've spent a lot of time this last year working on it and working up strategies around perianal Crohn's disease that we can use to take the area forward. My remit today is to particularly talk about the role of surgery within perianal Crohn's disease and what we actually are trying to do. And it's quite important to actually change things in terms of what you're trying to do, to actually categorize in terms of what you're trying to achieve with each aspect of the surgical involvement. And right at the beginning, for the general surgeon as well as the colorectal surgeon, often it's just about control of sepsis within the perineum. But later on, it's also about definitive treatment of the fistula, which means defining the anatomy, working out what's going on, and then thinking about achieving cure as well, but always with that aspect about continence at the back of your mind, particularly with patients with Crohn's disease who can have diarrhea not just at the time of presentation, but at any stage later in their life as well. So my personal approach is to go through and work in a very systematic fashion with the patient from first presentation through into hopefully getting them to either cure or certainly to at least a persistent asymptomatic state. And starting with that is really an examination under anaesthesia with drainage of sepsis and cetons, very early use of immunomodulation with the help of our gastroenterologists, both in terms of biologics and in terms of immunosuppression. Then sitting down with a patient and having a very detailed conversation about what the future is going to hold, what their expectations are, what they're likely to want to achieve, and also making sure that they have very realistic expectations about what can be achieved and what their future is likely to involve. If they do decide to go for an attempt at cure, and it is often just an attempt at cure, then I would talk them through the different stages of that process, which often, in my hands, would last between 6 and 18 months with a patient's pathway, where we look at stage procedures. And my strategy has always been to deal with simplification first, then to deal with secondary tracts, and then to deal with primary tracts outside of the midline, and finally to deal with the midline tracts, and most difficult of those is the rectovaginal fistula in women. So, managing sepsis. We don't see that many patients these days who have terrible disease. The concept of just putting a patient with Crohn's disease on antibiotics because they have a sore bottom is no longer really part and parcel of what we and our gastroenterologists do. We tend to have a look, particularly with new presentation of symptoms. And the importance of that is that you're trying to control infection in order to stop tissue destruction and to allow biological therapy to be introduced. And if that can't be done at a first examination under anaesthetic, then it needs to be done at a second and a third until things are controlled. Not doing so actually changes the patient's long-term prospects in terms of their chances of cure, but also their chances of a good functional outcome. So I'm just telling you what you all do already. It's really just looking at incising and draining where possible, really looking for the deep abscesses, particularly those that lie just underneath the levator plate, a very important group not to miss, and if necessary, to actually create the fistula, because that often does happen, is that you need to create the fistula in order to control the infection. It is going to happen irrespective of whether you do it, whether you do or don't do it. It's a case of really trying to minimize the impact of the sepsis and stopping it becoming a supralevator collection. If you're not sure as a general surgeon, you can certainly use MR, and I'll come back to that in a minute. But the other thing is just in terms of engaging an experienced colorectal surgeon early in the process. Cetons, obviously, if the fistula is obvious at first examination under anaesthetic. If it's not obvious and you're not experienced, leave it alone and bring the patient back another day for somebody experienced to have a look. So that means that there are usually subsequent EUAs for these patients, either that Crohn's disease isn't recognised at the beginning or that it is recognised and then you still have ongoing problems requiring further control. And control at this stage is really about defining the anatomy, working out which are primary tracts, which are the secondary tracts, and getting a ceton in to act as a form of control. It is possible to lay open extra sphincteric horseshoe extensions, and you might think about simplification with a view to definitive treatment. Simplification, to my mind, is not bringing a tract closer to the anus. It's actually often taking your incision further away from the anus. There's a little bit of evidence emerging now that actually the longer tracts, particularly those which are narrow bore, are actually easier to heal and to manage in the long term. So it's not necessarily the traditional idea of just bringing everything very close. You're all familiar with the classification already of perianal Crohn's disease fistulae. We very seldom see the subcutaneous ones, and they can be dealt with relatively easily. Intersphincteric, transsphincteric, suprasphincteric are the most common, but unfortunately, particularly in Crohn's, we do see a number of suprasphincteric fistulae, those that cross the levator plate, enter high in the rectum, most commonly seen when there is proctitis present in the rectum, but a very, very difficult set of patients to manage afterwards. There's no doubt that MR has a role to play. I don't think that there's necessarily need to do an MR before every examination under anaesthesia in perianal Crohn's disease, but at some stage you are going to need an MR scan to make sure that you have got good control, that the cetons are all in the right place, and actually, importantly, that there's no additional infection present. In experienced hands, some people use endoanal ultrasound. I use it occasionally in theatre if I'm having difficulty finding a tract or an abscess, but there are others who would use it routinely instead of MR. Very much a personal preference. This talk isn't really about medical treatment, but it would be really important not to gloss over it, because actually this is the fundamental part of what we're trying to do with perianal Crohn's disease, is to treat the underlying disease before we deal with the fistulae. And it's now well established that medical treatment, particularly with the biologics, known as the MAB group, infliximab and adalimumab, is most commonly used in this country, but also with the adjunct of using some other form of immunosuppression, most commonly azathioprine, but 6-MP is quite widely used as well. I would ask you all to talk to your gastroenterologists and make sure that the treatment is optimized. There are ways of making sure that you're getting the best possible treatment for your patient in terms of how the medical management is looked at and how it's monitored. There are a lot of patients out there who are actually getting no infliximab at all of any use to them in terms of controlling the disease, simply because they have antibodies to infliximab and nobody's looked for it. Secondly, there are ways of measuring your levels to make sure that you've got it well enough. Trough levels are routinely used. If your gastroenterologists aren't doing that for you, you really need to ask some questions about getting that aspect of treatment absolutely right. Because once that is right, you can then step in again. This is just to confirm the evidence now in favour of using biologics is really quite overwhelming. Some of these trials really importantly outline problems which we have in perianal Crohn's disease, which are about how outcomes should be defined. All of these early trials were very much aimed at healing, whereas actually more and more we're really talking about rendering a patient asymptomatic with good function. So, assessment of fistula healing, another complex area. There are so many ways of doing it, which will tell you that there's no good way. Most of the biologic trials have used a score called the Perianal Disease Activity Index. Patients don't like it because they don't feel it's particularly relevant to them, and there's a big move now to look at developing a set of patient-reported outcomes, and that's being done with a tool called the Anal Fistula Quality of Life, which is being done through St. Mark's. We hope to have the validation of that out next year. And we're also within the ACP running a COMET study looking at reported outcomes, not patient-reported outcomes, but reported outcomes at the moment, which will also give us a better idea of what we should be looking at to inform studies of the future. There are other ways of assessing whether something is healed. More and more MRI is being used. There's quite a lot of work being done in terms of MRI volumetrics now, and we're also developing a way of looking at MRI activity to see whether that will help overall. So, what is the evidence for multimodal treatment? It's not good. We've heard nothing that is particularly good in terms of randomized evidence. It's just not there. These are all small studies. They are starting to build up now to the point where we actually have a systematic review. 24 papers were looked at in detail, but only 8 of these actually looked at comparing in a non-randomized fashion between multimodal treatment and medical treatment or surgical treatment alone. In the medical-only treatment, the cetons were used. So it doesn't imply no surgery, it just implies that the only surgery used was control with cetons. In the surgical arms, they look at a number of different procedures, including fistulotomy, anal fistula plugs, fibrin glue, and transperineal repairs. And as you can see, success rates are low. We're looking at complete remission or a healing rate of 43% with monotherapy, and a slightly improved, but not statistically so, a healing rate with combination therapy. So what are the surgical treatments when we come to actually definitively closing a fistula? In terms of what we're looking at, we've talked already about cetons. Please don't dismiss them as a long-term option. If a patient's expectations are that they are rendered asymptomatic and can get on with a working life, then cetons are certainly an option and they should be considered. In very extreme circumstances, particularly where function is lost, you might need to think about something more radical in terms of stomas and proctectomy. So where does fistulotomy come in? In my book, it only comes in one place, and that is with the very superficial fistula and perianal Crohn's disease. When many of us would recognize that as actually a bridge. You often get skin bridges, and that would be one circumstance where you could consider laying it open. But there shouldn't be any sphincter muscle in your division. Loose cetons depends very much on the pattern of Crohn's disease. In this circumstance, you've got it as early control. In this patient, they're being used for palliation. You've got, despite optimized treatment, you've still got a small group who will go on to have persistent, very corrosive, erosive disease. And sometimes the only thing you can do is actually build up and control it as best you can. This patient almost inevitably will end up with a permanent stoma and possibly even a proctectomy, because even a stoma often doesn't rescue this group of patients from ongoing disease. The options, I've covered some of them briefly already that I'm going to look at in a bit more detail: of fibrin glue, the anal fistula plug. We'll talk a bit about advancement flaps, both endorectal and endoanal, a little bit about rectovaginal fistula repair, and some early evidence on lifts, and a couple of things just to whet your appetite for the future. So, what most surgeons do when it comes to this point is just take out the cetons. This is based on, it seemed like a good idea at the time, 2 studies which have described it in this country of induction of infliximab, getting the patient to a steady state, and then just taking the cetons out. And in fact, there is even a prospective randomized control trial where that's one of the arms at the moment. The PISA trial is running just that, looking at just early removal, leaving them in, and there's a third arm which is looking at using advancement flaps as well. The timing is quite important. I suspect that we're leaving it too long and that we're actually leaving cetons in to the point where they're epithelialized. If you are going to use this approach, I would suggest that you take out the cetons between 4 and 6 weeks after they are placed, provided the biologics are on board. In my hands, I think that ceton removal is probably best suited to secondary tracts, and that's the only place I would use it, because you're not really going to cure a fistula without doing something a little bit more. Fibrin glue has been used. You're familiar with the technique in terms of putting it in, a bleb on the outside, again on the inside, a very short track here, and almost certainly destined to fail. Has been used in Crohn's disease. There was a small prospective randomized trial done with fibrin glue against just observation, so in other words, not doing anything at all. quite a good control arm if you're choosing it in terms of wanting to get good results, and perhaps not surprisingly, Fibrin glue did rather better, but you will see the success rates. We're looking at only about 1 in 3 in terms of healing rates, and that carries on, that theme carries on the whole way through surgical treatments for Crohn's. The anal fistula plug, we have a much greater experience of using. It's been around for many years now. We're coming up to the decade of its use in the UK, and it can be used particularly for long tracks in terms of putting in, and I use it largely as an adjunct. There's a systematic review of 20 studies, none of them randomized, each with small numbers of patients, but specifically pulling out the Crohn's patients in there, and you can see quite favorable healing rates when you compare Crohn's fistulae to non-Crohn's fistulae. When we look at a systematic review of anal fistula plugs, again we can see that we're not looking at large numbers of, this is not a systematic review, this is a trial that was done. It's not large, but they did use it very nicely in terms of defining what they were going to do in terms of outcome, quite a difficult outcome to achieve in terms of closure at 12 weeks, but excluding large groups, which we see quite commonly. And again, you can see that we're looking at about a 1 in 3 closure rate, and the theme continues. Not significant, but what you would expect, I think, in most people's hands. The button plug has given us another option, hasn't been widely used. There is a small study where it's used in both pouch vaginal and Crohn's fistulae. 9 of them had Crohn's, and there was some success, but again, not high. The advantage of the button is in the early days it was literally a plastic button. It's now made of the same mesh material as the actual plug is made of. It can suture in and then it does disappear afterwards. The advantage of having the button is that you can anchor it properly to the internal sphincter, and it stops the early extrusion rate, particularly with short tracks. The endorectal advancement flap has been very widely used in Crohn's disease. There are a large number of studies that have been done with large numbers of patients involved. Again, looking at success rates, quite high, but a downside of a 1 in 10 incontinence rate as well. Looking at these big studies, taking all the studies together, there does not seem to be any particular difference in terms of technique, whether you just use the mucosa, whether you use a partial thickness with part of the muscle, or if you use a full thickness flap. There doesn't seem to be too much difference in terms of doing this. My personal problem is when I try and put this into practice, it's very hard to deliver, because the majority of patients in my practice have very scarred anuses. They've often got a lot of tissue destruction, there's a lot of fibrosis already, and gaining access to the anus in order to do a rectal advancement flap, I think is actually very, very difficult to do. More importantly, I think when you get failure afterwards, you actually make it much, much worse for the patient, not just because they end up with a much bigger and more difficult fistula to deal with afterwards, but also because they have changes in the sensation around the anus. So it's not just the traction on the anus, which is disrupting the sphincter muscle. I think it's also the cutaneous sensation around the anus makes it quite difficult to tell the difference between gas and liquid stool, making continence an issue. The lift procedure has again been around for a little while. Again, a lot of retraction on sphincter muscles in order to do it. You can see the fistula tract being taken out there. And unfortunately, what this tends to do, particularly in Crohn's where you have ongoing disease, particularly in the rectum, you will find that what you do is get conversion to an intersphincteric fistula, and that's one that you might be able to lay open with a cryptogenic fistula, but you would not want to lay open in Crohn's disease. Small series going across, all non-randomized, giving a degree of success, some of them quite high, none of them subsequently repeated, and the option here of putting in Certasys mesh as well to reinforce the mesh, not surprisingly, by the doyen Neil Ellis. So the over-the-scope clip is around. We have experience now of using it for about 2 years in Cambridge. We do use it in Crohn's disease, but we do not use it on the rectovaginal septum. And the reason for that, again, is that there's not enough tissue to hold it, and all you do is create a small fistula and make it into a huge hole in the rectovaginal septum. So please don't anybody go away from here thinking that they can use it for the group that they don't want to operate on, which is the rectovaginal fistula. You can't. But it can be used elsewhere, and it is quite well tolerated. We've adapted the technique from the German study. We do not excise a 2 centimetre disc. What we use is literally just elevation of the mucosa around the internal opening, and because it's circumferential, it pops back and gives you your access. You have to put sutures into the sphincter muscle to hold them on. 2 sutures will do it. It comes up they're held into the clip. This is the applicator, and that's what you end up at the end and cutting the sutures. No evidence for it yet. Something else where there is a little bit of evidence is the autologous stem cells. This is essentially fat, which is harvested from the patient. It's pulverized essentially and put in fibrin glue and then injected in a very similar way to fibrin glue. Some early healing rates, and recently the first results from a randomized trial out of Spain, which again show healing rates between 50 and 60, but it's very early days. Rectovaginal fistula is a specific circumstance which needs a lot of consideration about how you do it. Broadly speaking here, the one difference in terms of management I would mention is that I don't think you necessarily need cetons in a rectovaginal fistula unless there is ongoing infection within the rectovaginal septum or the perineal body itself. The reason for that is often they make the holes bigger and they render the patient more symptomatic. There are different approaches. You can go through the rectum, you can go through the vagina, you can go through the perineum, and lots of reconstructive techniques, which I'll touch on just a couple. In terms of looking at advancement flaps, particularly in rectovaginal fistula, it looks as though there is a reasonable success rate, but slightly favouring the vaginal approach rather than the rectal approach. Long-term results, again, these are very dedicated patients and surgeons who've often had several procedures to get there, but not terrible if you want to do it, about 1 in 2 at best. This is a Marsh's graft, which is interposition of the labial fat pad harvested from beside the labial into the perineal wound and closed up afterwards. Quite scarring in terms of disfigurement for the patient, but giving you good tissue to allow repair, and of course some risk of changing the shape of the vagina itself. A couple of finer points to cover. The first is that there are indications for a stoma. One thing we've learnt in terms of our work with patients over the last year is that a stoma should not be considered a failure. And they've asked us over and over again to get across to surgeons that actually it might be the best possible option for a patient, and often it should be discussed early. A stoma can be used in this situation to control sepsis if you really can't do it any other way, and you might want to think about it as a treatment option or where you have incontinence. Don't forget the option of proctectomy. You can make a stoma and still have a symptomatic perineum. In this case, you really are aiming for proctectomy, and you often need plastic reconstruction. So what are the unmet needs in terms of research for perianal Crohn's disease? Very elegant paper out of ECHO, which has just been released online, talks about looking at defining the natural history of perianal Crohn's disease, looking at better morphological description of the fistula tracts in order to help design research. Very big emphasis in terms of outcome measures, and of course the prospect of a randomized controlled trial. We are working on all of these areas at the moment, and you will shortly see a study coming out of the ACP called Enigma, which will be trying to address all of these areas within perianal Crohn's. So, in summary, the first thing that we need to do as surgeons is to control infection. We then need to engage our gastroenterology colleagues and keep an eye on them to make sure that they're doing it to the best of their possible ability to help in terms of dealing with the disease. You need to manage the patient really well in terms of counselling and expectations, and then in terms of managing the tracts, have a strategy. Decide how you're going to go about it, work it out for yourself, and try and map that out for the patient right at the beginning. As I've said, my simplified strategy is to go for simplification, secondary tracts, primary tracts, and then for the midline. Thank you very much.
Thank you very much. Thank you for inviting me to speak today. So I was asked to talk about the prevention and treatment of parastomal hernia, and the first thing to say is that this isn't done by myself. This and the position statement is a body of work done by collaborators from around the United Kingdom, and also importantly with the Association of Stoma Care Nurses, and we have a representative in Judy Hanley, the current chair in the group. So we all know what a parastomal hernia is when we see it. And there are many definitions in the literature of what a parastomal hernia is. This one from Russell Pearl, who was the professor of surgery in Chicago in the 1980s and 1990s, is probably the most widely used in the literature, and that a parastomal hernia is an incisional hernia related to an abdominal wall stoma. How common is it? Well, the true incidence is actually unknown. The great John Gallagher asserted that it was probably an inevitability if the patient had a colostomy. But the truth is that how common it is depends upon how long you follow the patient up for, what your method of follow-up is, whether it's clinical, telephone follow-up, or indeed radiological. But the risk is lifelong. I've seen patients who develop parastomal hernias decades after their initial surgery. And it also depends upon the type of stoma that the patient has. It seems to be more common in patients who have colostomies rather than ileostomies, and patients who have end stomas rather than loops. And that's to do with the way in which the bowel seals off the aperture in the fascia of the abdominal wall. In terms of its prevalence in the United Kingdom, we have between 100 and 120,000 patients with a stoma at any time. There are approximately 20 to 21,000 new stomas made each year. About half of those will end up being permanent. And if you survey patients and ask them, do you have a parastomal hernia? If you look around Europe, anywhere between 25 and 57% will report that they have a parastomal hernia at that time. So that's a significant burden of disease that we have out there. Why is that important? Okay. Well, the traditional surgical dogma, as asserted by Russell Pearl, was that most parastomal hernias are asymptomatic. Well, he clearly didn't ask any of the patients. And that's because if you do go and ask the patients all say, I actually have lots of symptoms. I get a lot of pain. Pain's one of the commonest problems they have. They get the appliances leaking, they don't stick properly, they get skin irritation from it as well. Only a quarter of patients report being asymptomatic. And some studies report that up to 30% of patients who have a parastomal hernia may need it fixing. Why is that a problem? Quite simply, because the outcomes are not that good. The results of repair, and we'll talk about those in more detail later, have traditionally not been great. There is a significant morbidity and mortality that occurs with repair, particularly in the emergency setting, with mortalities that can be greater than the original surgery that led the patient to acquire the stoma, and the recurrence rates have been significant. Unsurprisingly, as was already alluded to, in the ACP-GBI Delphi process, the prevention and treatment of parastomal hernias came out as the second most high priority non-cancer related area of research highlighted by the membership. And with that, we aim to provide the position statement for you, and I'll give you a summary shortly of where we're at. The idea is to use the grade recommendations as already alluded to by Nader, and we're formulating clinical questions in 4 key areas: the prevention, the diagnosis and classification of parastomal hernias, their management, particularly non-operative and working patients up, prior to then undertaking operative repair, and we will assess the quality of evidence and make strength of recommendations according to the grade guidelines. So first of all, prevention. The first person who is important in the process is likely to be the stoma care nurse. It's the person who the patient frequently meets prior to getting their stoma, and they go through the process of meeting the stoma care nurse, having the appropriate counselling with the aim of better psychological acceptance, better sighting. But is there anything that the stoma care nurses can do? Well, yes, there is. We as surgeons very rarely cross that barrier and go and look at the nursing literature. But actually, there's quite extensive evidence now for what our nursing colleagues do, and in particular their role in appropriate sighting, which you probably all are aware of, but in particular the use of support garments in the immediate post-operative phase. I have to say it's very rare that any of my patients seem to look this young or this slim, but also the use of abdominal wall strengthening exercises, which they teach patients afterwards. The Association of Stoma Care Nurses have now made their own guidelines, and the aim is to standardise care throughout the United Kingdom in terms of the use of support garments and abdominal wall exercises in the immediate post-operative setting. They are in print at the moment. They will be circulated to all 700 members of the ASCN shortly, and by the end of this year we should be hoping to see stoma nurse care standardised across the UK. What about the surgical techniques of making a stoma itself? Jacob Rosenberg is Professor of Surgery in Copenhagen, routinely states that the evidence basis for how we actually make stomas is only partially evidence-based. I think he's been kind. I don't think there's anything partial about it. There's very little out there. But what we will look at are some of the things that have been purported to be important, including the location of the stoma on the anterior abdominal wall. Does it come through the rectus sheath? Does it come through the rectus sheath but lateral to the muscle, the so-called LRAPS technique, as promulgated by Brian Stevenson? Or can you even come lateral to the rectus sheath and come through the oblique muscles? What about the size of the traphyne that you make in the anterior abdominal wall? We know that the size, as you get bigger, the larger the diameter, the larger the tangential force on that traphyne, and that's what makes it get bigger over time. So how big should the hole be? And then finally, what shape should the hole be? Do you make a cruciate incision? Do you make a circular incision and hopefully have the tension shared more equally around the circumference of the traphyne? Or do you just make a slit? Is there anything else that you can do as a surgeon when you're making the initial stoma to try and prevent the formation of a parastomal hernia? The role of prophylactic mesh has been discussed in the literature for nearly 20 years now in one form or another. And the original descriptions involved the placing of something like a synthetic mesh in the retrorectus position with a circular or cruciate traphyne in the middle of the mesh placed at the time of primary stoma formation. There have been a number of randomized controlled trials and indeed a number of systematic reviews and meta-analyses. Indeed, our group has written one of the most recent ones, which is currently in press with the Annals of the Royal College of Surgeons. And when you look at all the RCTs and you combine them together, you can see that on basis of clinical examination for detection of parastomal hernia, the use of prophylactic mesh seems to reduce the rate of parastomal hernia formation. So why aren't we all doing it? Well, I think it's because the surgeons look at the studies and go, that doesn't look quite right. There's something not quite right with the methodology. And like Jeremy Hunt, I think the methodology is really important and we as surgeons need to know about it. And when we look at those trials, they're underpowered. Most of them are single institution. They're heterogeneous groups of patients with short follow-up. They're poorly designed, with no standardisation of the control arm. They're poorly executed, inappropriate outcomes. It's a classic example of the McNamara fallacy. We measure what can be measured, and we ignore the things that we really should measure, which are important to patients. We pay no regard to those whatsoever, and we only look at the outcomes which are important to surgeons. We underreport harm. We've got no findings which are routinely replicated when they're implemented into practice. 2 studies have come out now looking at the role of prophylactic mesh when it's implemented as a quality improvement project, no improvement in parastomal hernia rates. And we've got no health economic benefit for using prophylactic mesh. So I remain, as you can tell, a skeptic. Moving on to the diagnosis of a parastomal hernia. How do you make the diagnosis? Well, in the old days, when everyone was slim and we didn't have the obesity epidemic that we have now, clinical examination had a place. And the trials that have been done, predominantly from Scandinavian countries, don't face the challenges that we face in the United Kingdom, where over 62% of our population are now overweight and obese, according to the Chief Medical Officer's report. Unsurprisingly, from North American literature, Australasia and the United Kingdom, we're now at the stage where I think clinical examination alone is likely to be insufficient because of the population we serve. And the European Hernia Society have now stated that CT scanning is probably your reference standard, not least because it tells you when things like this are occurring, where you have local recurrence in the anterior abdominal wall, for example. But how do you do the CT scan? That might be important. Do you do the standard follow-up CT scan that you have for your colorectal cancer patients? The patient is in the supine position. But what about if you do it prone or in the decubitus position and with a Valsalva manoeuvre? You can quite clearly see here, there is no obvious parastomal hernia, but when in the semi-prone position with a Valsalva manoeuvre, the parastomal hernia becomes obvious. We're not quite certain yet what is the best technique for CT scanning. There are a number of classification systems that have arisen because of increased use of cross-sectional imaging. This from colorectal disease in 2009 was published by a Spanish group led by Moreno Matias, and it describes parastomal hernias in patients who've got a permanent end colostomy. And it tries to relate the complexity of the hernia from one where there is no obvious parastomal hernia visible, all the way up to parastomal hernias where there are small bowel loops in the hernia sac. There is limited evidence that it relates to the need for surgery or the symptomatology that the patient gets. Better might be the European Hernia Society classification, which tries to incorporate the presence or absence of a concomitant incisional hernia. This is driving more towards the technical challenge that operative intervention might present to the surgeon. As I'm sure you can see here, we have a primary parastomal hernia, which is relatively small with no concomitant incisional hernia. This patient is in a very different position to the patient who has a class 4 parastomal hernia, where there seems to be almost complete failure of the anterior abdominal wall with a large concomitant incisional hernia and a large parastomal hernia containing multiple loops. The EHS class 4 is a synonym of terms in the literature such as complex abdominal wall hernias or patients who need complex abdominal wall reconstruction. And we are dealing with quite a wide range of problems that these patients may face. So are we talking about the same thing when we talk about parastomal hernia? Clearly not. There's a wide range of the problem. So how do we move forward towards repair? This is from Philip Muisums, who's one of the European Hernia Society's leads in terms of derivating their guidelines, who published this very nice synopsis about how you get good quality outcomes in any hernia repair. He talked about the patient, the prosthesis, and the procedure, the triple P triangle, leading to good outcomes and relating it to complications, quality of life, and recurrence. I think that's good, but it derives from a European model of surgery where most of the patients don't have any waiting list time where they sit around. They go and see the surgeon and they get operated on relatively quickly. That's not the scenario in the NHS, and you probably, like me, have a long waiting list, and patients, particularly with benign disease, can wait for some time. And I'm going to add a fourth P and think it should be a diamond, not a triangle. It's also about the pathways of care that we have to have for these patients, incorporating the multidisciplinary team like your stoma nurses and plastic surgeons and so on. And it pertains to those important things relating to patient optimization, like weight loss, exercise, smoking cessation, and choosing the right patients to operate on. So first of all, the patients who have a parastomal hernia, can they optimally be managed with a non-operative management paradigm? Well, the answer to that is clearly yes, but it's not done by surgeons. We almost never see these patients. The overwhelming majority are dealt with in an expert fashion by our stoma care nurse colleagues. And I use the example here of the Association of Stoma Care Nurses committee, including Judy, who is part of our consensus group. There are now standardised guidelines by the ASCN as to how to manage these patients in a non-operative fashion with appropriate support garments, altering the bags and appliances that the patients use. What is the threshold for surgical treatment of parastomal hernia? How do you decide to move from the non-operative management to when it's time to intervene? That is probably one of the most challenging questions for us to answer. The absolute indications are relatively straightforward. You see them on the acute emergency take. You'll see patients who've got evidence of bowel ischemia or those who've got non-resolving small bowel obstruction. In those circumstances, the aim is to save the patient's life. It's not about fixing the hernia definitively. The standard principles that we're all aware of from things like the National Emergency Laparotomy Audit hold true. After that, in the elective setting, all other indications are relative. If you're thinking about operating on a patient, what steps should you consider taking as part of their optimization and preoperative planning? I would contend that the first thing to do is to define the anatomy so you can plan your operative approach. And I think a CT scan is essential for that because it delineates the abdominal wall musculature. But importantly, it also enables you to exclude occult disease like this patient who had a metachronous cancer hiding inside their abdomen. And the standard things that we're all aware of nowadays about optimizing our patients in the elective setting for things like correcting anemia, optimizing diabetic management are all important. Smoking cessation, there is now enough literature from the abdominal wall reconstruction literature to say we really should be doing this, particularly if a patient has large skin flaps, the rates of necrosis are very high, leading to poor outcomes. Weight loss to get patients' body mass indices down under 35 is important. It reduces complications of infection, recurrence, and so on. And optimizing patients' fitness by getting them to do more exercise, it only has to be walking. It doesn't have to be riding the Tour de France or anything like that. Simple measures are effective. What steps should you consider taking to identify and mitigate risk and obtain informed consent? For the patients who have the more complex abdominal hernias, where you've got incisional and parastomal hernias that you may have to tackle, it might be prudent to consider some of the more intensive assessment with things like cardiopulmonary exercise testing to assess their fitness and to enable you to have an appropriate informed discussion about the risk and how you might offset some of that with using high dependency care, for example. You are bound by the same duty of care to these patients in obtaining informed consent. What you are often aiming to achieve in the elective setting is an improvement in the patient's quality of life. So carefully weighing up the risks and benefits with that patient according to GMC guidelines remains essential. In terms of tackling the operative repair, there are a number of things that can be considered, including do you do a suture repair or do you use mesh? Do you use a laparoscopic or do you use an open approach? Where do you place the mesh in the anterior abdominal wall, and what type of mesh should you consider using? Well, essentially the data that's out there is poor quality. It's retrospective observational data with small numbers in single institutions usually. We have no classification of the different types of hernia that have been attempted to be repaired. The follow-up's short, it's poor quality, and there's no quality of life or patient-reported outcome measures there, which is very disappointing. There are no randomized controlled trials out there to inform us of what to do in these circumstances. So essentially what we have is this. It's apples versus oranges all the way. There's been one attempt at trying to bring all of this together by Bibi Hansen, one of the doyens of parastomal hernia surgery from Nijmegen in the Netherlands. In her seminal systematic review in Annals of Surgery in 2012, she summarized the evidence. The upshot is the data's poor quality and the recurrence rates are high. But the issue is recurrence rates is what matters to us as surgeons. Yes, it matters to patients too, but the patients have a whole other agenda as well. They're interested in the chronic pain, the mesh complications, the rigidity that occurs often with them, seromas, infection, quality of life, function. Can they get their appliance to actually stick on the anterior abdominal wall? Do they have to go and see the stoma nurses more often? That's not reported in any way, shape or form, disappointingly. And finally, is stoma relocation associated with low rates of parastomal hernia recurrence? Because it remains an option in those difficult situations. Well, stoma relocation can be performed with and without laparotomy to the same side or to the other side. Essentially, the recurrence rates of parastomal herniation are high, and then you have the issue of incisional hernias at the old stoma site. So where are we at? We've formulated the questions. We've done most of the evidence searching already. We've got to do formal grading of the evidence, and we're making the relevant statements hopefully by the end of September. But in summary, I think you'll see that we have what is a relatively common but potentially complex problem. Prevention may be better than cure, but it's far from certain. And when it comes to repair, the data is lacking. Thank you.
Thank you very much.